Okay, good afternoon, everyone, and welcome to this webinar on hemoperfusion in pediatric patients. Gabriella Bottari is talking, and now I am presenting you our agenda today. We have two talks about two colleagues, specialists in pediatric nephrologists and pediatricians. The first one will be Rachel de la Cruz, and the second one, Wiguo. I hope to say well the name. And we will cross some important topic about the extracorporeal blood purification therapy, and then we will discuss together about hot point in this field. Then we will open to answer also to your question. And before to start with the presentation of the first speaker, I will say that it's a pleasure to be here today. Thank you to Jafron for this kind invitation, and thank you to my colleagues and to the audience to take part to this so interesting event. Just a very short introduction about myself. I am Gabriella Bottari. I am a pediatric intensivist at the Children's Hospital Bambino Gesù in Rome. My field of interest is about the extracorporeal blood purification in pediatric intensive care. And then we move to our colleague, Dr. Rachel de la Cruz. She is the head of the hemodialysis unit in the Philippine Children's Medical Center. She will give us a very nice overview about extracorporeal blood purification in children, and then she will focus on some clinical case that she with her team have nudged. So Rachel, please start with your presentation.
Okay.
I stop my sharing, and yeah, you can start.
Okay, let me share my screen. Okay, can you see my slides?
Yes. Yes.
Okay, so
Right.
good morning in Italy, I think, or good afternoon, and good evening here in our part of Asia. So this is my talk, Clinical Applications of Hemoperfusion in Children, the PCMC Experience. So my task is to share the applications of hemoperfusion in children, and let me thank Jafron for having invited me to talk about our experience. So this is our hospital, the Philippine Children's Medical Center, and it is located in Quezon City in the National Capital Region, and is one of the government-owned and controlled corporate national centers for specialized healthcare under the Department of Health. So it has a 200-bed capacity children's hospital, and our hemodialysis unit just operated more than 2 years ago with a 10-station capacity treatment area. So the outline of my talk will be talking a little bit on adsorption as a mode of solute transport, about cytokine storm and the role of and use of hemoperfusion and plasma perfusion in the management of childhood diseases, and I will be sharing our experience in our center. So as a pediatric nephrologist, when we talk about renal replacement therapy or renal support therapies, I always start with basic principles to facilitate understanding, and this would include the 4 major transport mechanisms. 3 of these are for your solute transport or solute clearance, and these are your diffusive clearance, convective clearance, and adsorption. The fourth transport mechanism, which can be seen on the right side of your screen, is solely pertaining to fluid transport, and we call it ultrafiltration. The third transport mechanism for solute, which is adsorption, is our topic for this webinar. So the process of separation of a mixture into its constitutional species is not a spontaneous process and requires an expenditure of energy. So if a mixture exists in a single homogeneous phase, different processes must be applied to obtain separation. Such mixtures such as by barrier, by solid agent, and by external field or gradient. So in clinical settings, blood purification techniques rely mostly on your number 2 by barrier and by number 3 by solid agent. And this separation of barrier are the most used. So when diffusion and convection are inadequate to remove the target molecules from the patient's blood, the use of sorbents and hemoperfusion may become an additional option for blood purification. So hemoperfusion involves passage of blood through a hemofilter where mediators are adsorbed to the membrane surface or through a sorbent-containing cartridge. So sorbents for extracorporeal blood purification can be divided into two categories. First are those that have hydrophobic properties and therefore adsorb molecules in contact with the sorbent. And second would be those that eliminate solutes by chemical affinity. So the non-ionic macroporous resins are made of microsphere agglomerates which adsorb toxins in their surface. So the mechanisms by which it works are the molecular sieve effect of 3D network structure via your lipophilic hydrophobicity of molecular groups and via van der Waals interaction between resin molecular groups and adsorbed substances. So in hemoperfusion, blood is circulated through a cartridge containing the solid sorbent material. Solute removal and blood purification are obtained by adsorption or binding of these molecules onto the sorbent particles. So in our unit, we usually follow the second circuit diagram, the lower diagram here, wherein we use a dialyzer together with the adsorption cartridge to form a series in order to dialyze our blood prime. So this is often the case because majority of our patients requiring hemoperfusion have their extracorporeal circuit volumes exceeding 10% of their blood volume. So we have a protocol in where we use diluted PAC-RBC as priming for this circuit, and we dialyze this blood prime for about 10 minutes before connecting the circuit to the patient. So blood purification through sorbents have been used for disease conditions, and these are for your CKD5, your poisoning, immune disease, critical disease, hepatic failure, and lupus. So let me first talk about sepsis. So traditionally, sepsis was viewed as an excessive systemic pro-inflammatory reaction to invasive microbial pathogens. It has been proposed that the early phase of hyperinflammation is followed or overlapped by a prolonged state of immunosuppression. So as you can see in this diagram, there is a dive in the immune function of the patient with sepsis. This is referred to as a sepsis-induced immunoparalysis. There is decrease in the glycolysis, in the Krebs cycle, and even in the triglyceride metabolism, all of which are vital for the patient's survival. It is in this immunoparalytic state that is characterized by impaired innate and adaptive immune responses and may play a central role in the pathogenesis of tissue damage, multiple organ failure, and death induced by sepsis. So infections may provoke damage not only as a consequence of virulence of pathogen. The innate immune system associated molecular patterns like your PAMPs and DAMPs can trigger various pathways beyond the target defense against the microorganism or tissue remodeling. So the innate immune system is activated by the binding of the PAMPs on pattern recognition receptors, resulting in the release of inflammatory cytokines. Those cytokines represent the final step of cell signaling. So PAM stands for pathogen-associated molecular patterns and are derived from microorganisms and thus drive inflammation in response to infections. On the other hand, DAMP stands for damage-associated molecular patterns and are derived from host cells including tumor cells, dead or dying cells, or products released from cells in response to signals such as hypoxia. So during an infection, the cytokine genes are upregulated, and after fighting the infection, these genes return to their normal state. When cytokine genes remain upregulated, the products drive into a state of permanently activated cells, and the cytokine release induces cytokine production and release, which in turn aggravates cell and organ damage and may lead to an outgoing vicious circle, which is also known as the cytokine storm. So this is an amazing imagery of what probably a cytokine storm looks like. It brings havoc to areas where it hovers. So as you would appreciate from the lower part of this diagram, the cytokines have different sizes. There are those that are larger than the others, like here. As you can see, TNF-alpha is larger than your interleukin-2. So in reality, cytokines and other inflammatory mediators are large molecules. Their weights are in kilodaltons. So 1 kilodalton is 1,000 daltons. For example, the size of your IL-10 here, the size of your IL-10 is less than 20 kilodalton. That is around 16,000 daltons. So that is a large molecule, comparing it to like urea, for us nephrologists, which only has 60 daltons in molecular weight. As you can appreciate in this slide, a lot of your cytokines fall within the 11 to 30 kilodaltons, or 11,000 to 30,000 daltons molecular weight. The interferon gamma here is a bit larger because it has a molecular weight of 35 kilodaltons. And when you look at the TNF alpha trimer here at the end of this picture, this has a molecular weight of more than 50 kilodaltons. So this becomes important because those that are removed by hemodialysis are those that are small molecules, and the bigger the molecule becomes, the harder it is to remove through dialysis. So the smaller molecules can be, the smaller to middle-sized molecules can be removed by hemodialysis and even by CRRT, while adsorption is needed to remove the very larger molecules such as cytokines presented here. Now we go back to sepsis. So what are the cytokines associated with sepsis? These cytokines that are shaded in purple are commonly seen in septic patients as reported in journals. They are divided into the pro and anti-inflammatory cytokines. So the pro-inflammatory cytokines here are TNF-alpha, IL-1, IL-6, IL-12, interferon gamma, and your macrophage migration inhibitory factor. And your anti-inflammatory cytokines are your IL-10, TGF-beta, and IL-4. So when you look at the TNF-alpha, again, this is a cytokine that is very active in sepsis. It has, again, a very big molecular weight. So if you need to remove this, I think you may need to do hemoperfusion. So in sepsis, capillary leak represents the maladaptive and undesirable movement of fluids and electrolytes with or without protein into the interstitium. So in sepsis, the global increased permeability syndrome, or GIPS, is seen in patients with persistent systemic inflammation resulting in continuing transcapillary albumin leakage. So your GIPS may represent the third phase in a continuum after the first hit by cytokine storm, followed by the second hit, which is an ischemia-perfusion injury. So this is a potential indication to start blood purification therapy. Now we go to dengue, as our country is endemic to dengue. So this is a more popular condition that we see and refer to our service. So here is the clinical course showing the three distinct phases. The febrile phase, this is when the patient develops sudden onset of high fever and is often accompanied by headache, myalgias, and your gastrointestinal symptoms. This phase usually lasts 3 to 7 days, during which time the viremia peaks. So the second phase, which is also called the critical phase, This commences around time of effervescence, lasting 2 to 3 days period. It is here when the severe complications can manifest in a small proportion of patients. And the final phase is the recovery phase for 2 to 5 days when the patient's symptoms resolve and clinical parameters normalize. Here, you would appreciate that the host inflammatory response is simultaneously followed by the capillary leakage, which in its peak during the critical phase may lead to shock, and this is what we see in patients referred to the PICU and eventually referred to us. So the dengue virus-infected cells release inflammatory mediators, immune complexes are formed, and the complement cascade is activated, resulting in increased vascular permeability and hemorrhagic manifestations that characterize severe dengue. So mechanisms are not completely understood, but there is evidence that reactive oxygen species, enzymes, and pro-inflammatory molecules actually break down the endothelial glycocalyx layer, allowing plasma to reach the underlying intercellular junctions and leak out of the blood vessels. So this is a proposed model by Rothman, which the dengue virus produces a capillary leak syndrome. So the monocytes are thought to be the primary cellular target for dengue virus. So serotype cross-reactive antibodies present at the time of the second dengue virus infection bind to virions without neutralization and then enhance the entry of the virus into the monocytic cells, expressing the immunoglobulin receptors as shown in the left side of the diagram. Okay, so serotype cross-reactive, the memory T cells, also present at the time of the second dengue virus infection, recognize viral antigens in the context of a class 1 and 2 major histocompatibility complex molecules. These T cells produce cytokines such as your interferon gamma and tumor necrosis factor alpha and beta, and lyse dengue virus infective monocytes. Your TNF-alpha is also produced in monocytes in response to dengue virus infection and or interactions with T cells. So these cytokines have direct effects on the endothelial cells to induce plasma leakage. The interferon gamma activates the monocytes to increase the expression of your major histocompatibility complex molecules and the immunoglobulin receptors and the production of more TNF-alpha. So the complement cascade activated by these virus antibody complexes and by several cytokines release the complement anaphylate toxins, the C3A and the C5A, which further increase capillary permeability. Also, the IL-2 may contribute by facilitating T-cell proliferation. So looking back again into this diagram, showing now just the mentioned cytokines in severe dengue. So they are now colored blue, and these are your TNF-alpha, IL-6, IL-8, interferon gamma, IL-2, and your TNF-beta. Again, the cytokines are very large and falls under the category wherein you need adsorptive devices for possible efficient removal. So now let me go to another disease condition wherein blood purification is helpful. So pediatric acute liver failure is a rapidly evolving condition that differs from adults with acute liver failure in areas of etiology, management, and outcomes. So it comes with a transplant-free survival of 55%. And it is associated with accumulation of various toxic substances such as ammonia, bile acid, or nitric oxide, lactate, and mediators of inflammation, which impair liver regeneration. So the hepatic toxins are mainly albumin-bound, and they cannot be removed by your conventional hemodialysis. And these are the toxins. And these toxins are important in the pathogenesis of end organ dysfunction. They also play a role in alteration in vascular function and acid-base balance. But what, like I mentioned earlier, that they may impair liver regeneration. So there is lack of detoxification, there is lack of metabolic and regulatory functions of the liver. all leading to life-threatening complications such as kidney failure, encephalopathy, cerebral edema, severe hypotension, susceptibility to infections, all culminating to multiple organ failure. So the only established therapy is liver transplantation, but majority of these patients die while waiting for transplant because of shortage of available donors. Potentially reversible and considerable work has been carried out over many years to develop effective liver support devices. So let me talk on non-bioartificial liver support system, or your NBAL. So it banks on the idea that removal of toxin alone may allow biotransformation and recovery of biosynthetic and metabolic functions without additional synthetic activity. Although the primary aim of using a liver support device is to improve the transplant-free survival of patients with liver failure, the alternative objectives may be to serve as effective bridge to liver transplantation, prevent the occurrence of liver failure in those that are predisposed to it, or provide functional capacity to improve organ dysfunction. So it is indicated in the early and middle stages of liver failure caused by various factors, patients whose prothrombin activity is between 20 to 40%, and patients who are in the end stage of liver disease and waiting for liver source for liver transplantation, or who are in the rejection phase after the liver transplantation, or whose transplanted liver is in the non-functional phase. It is also indicated in patients who have severe cholestatic liver disease with no effective results and after medical treatment, or patients with severe hyperbilirubinemia caused by various factors. So these are the contraindications for your non-bioartificial liver support system: active bleeding or DIC, serious allergies for the blood products or drugs used in the treatment, unstable hemodynamics, unsteady phase of infarction caused by cardiovascular and cerebrovascular accidents, especially in the adults, if there is extravascular hemolysis and severe sepsis. So when talking about the non-bioartificial liver support system, three modalities come into mind, and these are the plasma exchange, molecular adsorbent recirculating system, or MARS, and a plasma perfusion. For this talk, I will focus on plasma perfusion. So plasma separation technique is applied to filter out the plasma, and the plasma will flow through a perfusion apparatus containing solid adsorbents. So there is no contact between blood cell components and adsorbents. So currently there are two types of plasma adsorption. You have your neutral resin plasma adsorption and an anion exchange resin bilirubin adsorption. And the third would be a combination of the first two. So for the neutral resin plasma adsorption, this perfusion device is a broad spectrum sorbent which can adsorb substances with a relative weight of 500 to 30,000 Daltons. It can adsorb substances that cause hepatic encephalopathy, such as your ammonia. So systemic circulation of your pro-inflammatory mediators, particularly cytokines, such as the IL-1B, IL-6, and TNF-alpha, may have permissive or direct effects on development of hepatic encephalopathy and cerebral edema through a modulation of the endothelial permeability to neurotoxins and changes in cerebral blood flow. So this cartridge has strong adsorption for these inflammatory mediators. The second type of plasma adsorption is using the anion exchange resin bilirubin cartridge. As you can see in the third picture, it is depicted that ionic bonds are generated by electrostatic attraction between positively charged and negatively charged ions, which happens when bilirubin and bile acids are exposed to these surfaces. So DP mass is a combination of the two cartridges and uses a plasma separator to separate plasma successively, and the separated plasma is continuously adsorbed by two adsorption cartridges, namely your BSC30 containing the ion exchange resin and the macroporous resin containing cartridge. After this, the clean plasma is returned to the patient. So it offers an advantage because it has an efficient method to fully and constantly remove the medium and macromolecules and protein-bound toxins while specifically eliminating the bilirubin without the need to supplement plasma or replacement solution. Aside from being less costly than, for example, the MRS treatment, plasma perfusion techniques offer another advantage, which is it can be carried out using a CRT machine or a dialysis machine. So here, the cartridges are compatible with what is available in most hospitals. So having said that, you can actually use 2 dialysis machines or 1 dialysis machine and 1 hemoperfusion machine as seen here in this picture. So now I'll be sharing with you some of our experience in our center. So this is our hemoperfusion history started with this patient. This was in 2018. This patient was a referrer from another hospital and was transferred for ICU care. So this was an 11-year-old female, 48 kilogram with dengue severe, coming in as a referral to nephrology on day 6 of illness, day 0 of febrile of the dengue, with a platelet of 4,000. Fluid overload on referral was 17%. This patient was already on epinephrine and dobutamine. Chest x-ray showed bilateral pleural effusion. So the patient was also started on Vanco and Pipte. So the patient was having a urine output of 1.6 cc per kilo per hour. So we had a very long turnaround time. So that's why the patient's fluid overload increased to 10.1 liters by the time we started the renal support therapy. So moderate bleeding around the catheter insertion site was noted, and further chest x-ray showed rapid progression of the pleural effusion. So this patient actually received 10 hours of your prolonged intermittent renal replacement therapy, then was given another 5 hours because our machines only have a maximum total treatment of 10 hours. So PIRT, or your prolonged intermittent renal replacement therapy, is like your hemodialysis but is delivered in a very slow and prolonged treatment and may last from 6 hours to 12 hours. As you can appreciate from this slide, we were able to ultrafiltrate a liter for the first 10 hours. However, since this patient is still in the critical phase of dengue, the total drip rate of the intravenous fluid was not yet decreased because of shock. Of course, when the patient is off the PIRT, the patient will still have increase in the fluid overload again. It was only after the second PRT session that there was significant decrease in the fluid overload. This was done for another 8 hours. So as for the albumin level, this patient really had a very low level at baseline with a level of 13 gram per liter. So even if we have ultrafiltrated this patient on the 3rd hospital day, that being the day 8 of illness, still a febrile, with febrile episodes as high as 38.4, she remained tachycardic. She was noted to be irritable, scleromatous, and with puffy eyelids. So sepsis was considered as her liver enzyme, her CKMB, and procalcitonin were all elevated. So we decided to do hemoperfusion using the HA330 cartridge. So this is our setup. ECV is around less than 400 mils. That's, I think, 380 mils. So we have to give a blood prime. The blood prime, the ECV is around 11 to 12%. So, and this is when we initiated treatment. The blood goes first through the sorbent cartridge and then goes to the dialyzer pertaining to the blood prime. So we dialyze first the blood prime for 10 minutes before we hook the circuit to the patient and the start treatment. So the area shaded in orange here denotes the time allotted to hemoperfusion using the HA330 cartridge. So this was done for 3 consecutive days. The hemoperfusion treatment would usually last 2 hours to 2.5 hours. Each session of hemoperfusion was followed by hemodialysis, which was tolerated well. So on the 6th hospital day, she demonstrated improvement in her vital signs and no more febrile episodes nor tachycardia. Bilateral pleural effusion was also resolved. She was also extubated on the 6th hospital day. repeat procalcitonin was decreased at 0.54 microgram per liter. So she was discharged eventually on the 20th hospital day. So now let me share with you some of our experience in patients with severe dengue. We started treating patients in 2018. As for last year, as our hospital had a total of 1,114 dengue admissions, with peak of admissions occurring during the rainy months, and it peaked during the months of August and September. Of these admissions, 200 patients were PICO admissions, and 11% of those with severe dengue admitted at the PICO were subsequently referred to nephrology service for renal support therapy. They are referred because of the occurrence or development of early fluid overload and multiple shocks occurring early in the critical phase or just about to enter the critical phase. As we know, the critical phase will last around 2 days. So here is a 7-year-old female, 19 kilogram, also with dengue severe, referred to us during the day 6 of illness and day 1 of febrile with a platelet of 15,000. Fluid overload was at 13.1%, and before initiation, it already has gone up to 15.6%. So this patient had multiple shocks before referral, requiring fluid resuscitation. This is the reason also why the fluid overload reached 15%. So we decided to do hemoperfusion first before PIRT in the hope that that she will be able to better tolerate the ultrafiltration. Here, the baseline albumin was also low at 13. She was able to tolerate the significant ultrafiltration that is around 5 to 6 cc per kilo per hour. Of course, as expected, when patient is not on hook to the PIRT, the fluid overload will again rise. So the patient received 2 sessions of combined hemoperfusion and PIRT, and then followed by PIRT. So also the HA330 treatment was paralleled by a significant decrease in vasopressor need, as will be appreciated in this slide, occurring after the second hemoperfusion treatment. So this patient received norepinephrine, dopamine, and dobutamine. Here you would see that there is also decrease in the drip rate after the second hemoperfusion treatment. Also, there was significant increase in the urine output after the second treatment, although this may have also coincided with the patient crossing over the critical phase to the recovery phase of dengue. Likewise, there is improvement of the PF ratio, showing improvement in the hypoxemia. However, the procalcitonin went up, although the patient significantly improved clinically and survived. This may be an example wherein procalcitonin may not be a good marker to monitor improvement in patients undergoing hemoperfusion. So another case is a 7-year-old male, 23 kilograms, suffering from dengue severe, having been referred to us in the nephrology service on day 5 of illness, day 0 of febrile with a platelet of 13,000, with fluid overload percentage before initiation at 20%. So initially he was admitted at the ER going day 4 of illness and presenting with shock, and he was transferred to ICU. So the initiation of treatment was already at the FO. At initiation of treatment was already at 20% because this patient had 6 shocks before HP treatment, for which fluid resuscitation was given because of ongoing severe plasma leak. So this patient was intubated, anasarcus, bleeding per NGT and mouth, decreased breath sounds on the right with distended firm abdomen. So this patient underwent hemoperfusion, then was followed by 12 hours prolonged intermittent renal replacement therapy. The patient was able to tolerate significant ultrafiltration, leading to a decrease in fluid overload of 15% from a baseline of 20%. He again received HP treatment the following day, now followed by just 5 hours of dialysis. Again, there was significant drop in the fluid overload. Here we can appreciate that the patient actually tolerated higher volume ultrafiltration in a shorter period of time. This one, we have reached at least a 6 to 7 cc per kilo per hour net ultrafiltration with our PIRT. We decided not to give a third hemoperfusion session because the patient already had good urine output after the second HP session. The fluid overload is resolving already, and however, this patient developed pediatric acute respiratory distress syndrome 3 days after the last PRT session, requiring to do another HP treatment. So as for the pressor requirement, there was significant reduction following the second hemoperfusion treatment. So this patient was started on epinephrine, dopamine, and dobutamine. So again, here the total drip rate was decreased significantly after the second treatment, and there was increase in urine output. This happening altogether during day 1 afebrile going day 2 afebrile. So the initial PF ratio was really bad at 59. We were not able to get another ABG since this patient have a very low platelet level. Again, there was a note of increase in procalcitonin. This patient was discharge improved. This is a different case, also referred last year, July 2019. This is a 7-year-old female, 27 kilogram, presenting with 3 days history of undocumented fever, subsequently referred to the pediatric hemo-oncologist because of pancytopenia. So her BMA showed histiocytes, as seen here, engulfing other hematopoietic cells. So she also had diastolic dysfunction and hepatitis. Her final diagnosis was hemophagocytic lymphohistiocytosis, or HLH, secondary to infection. Her ferritin levels were rocket high, so they were more than 100,000. And we gave 2 hemoperfusion treatments resulting to marked decrease in ferritin levels. Although there was marked improvement in her clinical status after, even after just the first hemoperfusion session. So now let me share our experience with acute liver failure. We have performed, this is a 7-year-old 33 kilogram child with idiopathic acute liver failure. We have performed single plasma adsorption with bilirubin cartridge. So as I mentioned, we don't have the CRT, so we use 2 hemodialysis machines in our unit, and this is our setup. The first hemodialysis machine was for the plasma separator, and the second machine was responsible for pumping the flow of the separated plasma into the anion exchange resin cartridge. So for the proper binding of the bilirubin and other hepatic toxin, the plasma flow needed to be reduced to 25 to 30% of the set blood flow rate. So here our blood flow rate is 180 ml per minute with a plasma flow rate of 50 ml per minute. As you can see here, the patient's blood has passed through the plasma separator, and this picture was taken on initiation of treatment. Later, the separated plasma is pumped. That was, as you can see, the plasma that was separated is dark yellow. On the second picture, it can be appreciated that the plasma becomes less tinged after passing through the cartridge. Now the plasma becomes straw colored. So when we were doing the procedure, there was a blood leak in the plasma separator because we had problems with the access. So make sure you have vascular access is very good. I think this setup can be used without blood priming for children, for us in our unit, weighing more than 25 kilograms, because the extracorporeal circuit volume of the plasma circuit, of the blood circuit, I mean, is 180 mils already. So if the patients weigh below 25 kilograms, we need to do diluted pack RBC priming of the blood circuit, and this would entail putting in the series a dialyzer. So having mentioned that you need to do a diluted pack RBC priming, we just prepare a diluted pack RBC of 250 cc And this means you have to get 160 of packed RBC and 90 cc of plain NSS to target a hematocrit rate of 35. So as this depicted here, there is significant drop in the bilirubin level of about 40% after undergoing single plasma adsorption with the bilirubin cartridge. However, this patient did not survive. We were not able to do the cytokine adsorption as intended at that time. So what are the learning points? The body of evidence to support the use of blood purification such as hemoperfusion and plasma perfusion is growing. There is trend towards hemodynamic improvement, and this blood purification may potentially serve as a bridge to stabilize patients who are critically ill and patients with liver failure until more definitive therapies take place. And lastly, hemoperfusion and plasma perfusion is technically feasible in children. So thank you for listening.
Okay, thank you, Dr.
Let-
De La Cruz, for this nice talk. And I invite you to start if you want to answer in Q&A toolbar. You have lot of questions about your topic, and then we will discuss together after the next talk. Now move to the next speaker. We have Dr. Riguo. She is a pediatrician from the West China Second University Hospital, Sichuan University, and she will give us an experience, clinical experience about hemoperfusion in pediatrics with particular attention with some hyperinflammatory clinical disease. So, Dr. Rigo, please go ahead. I stop to share the screen.
Okay, thanks for your introduction. Okay, thanks for your introduction. I'm glad to meet everybody here. Now, the topic I'm going to share with you today is hemoperfusion therapy in pediatrics, channel experience, and expert concerns. Next, I will share with you the definition, principle, and application in pediatrics and points for attention in the application process of hemoperfusion. First, let's take a look at what is hemoperfusion. Hemoperfusion is a kind of blood purification therapy or treatment method which can lead the patient's blood from body to the extracorporeal circulation system and absorb poisons, drugs, and metabolites through the adsorbent in the perfusion device, so as to eliminate the substances. It can be combined with other blood purification methods to form different hybrid blood purification therapy. Now, this is a simulation of hemoperfusion technology. The main principle of hemoperfusion is adsorption. When blood flows through the adsorption column, target molecules such as inflammatory mediators, opioids, drugs, and antibiotics are absorbed in the column to achieve the purpose of blood purification. To say concretely, for example, A substance about the size of the sample can be absorbed in a kind of relatively specific. But if the material is smaller than the size of the sample, it can't be absorbed, such as water and small molecular substances. If the material is larger than the size of the sample, such as protein and blood trap components, we steam the tunnel. For the Hemoperfusion began in 1946 and has been developed for more than 70 years. The development of adsorbents is also changing with each passing day. The broad spectrum absorption materials are achieved carbon and resin. There are also some specific adsorbents such as bilirubin adsorbent or for hyperbilirubinemia, endotoxin adsorbent for sepsis, LDH adsorbent for atherosclerosis, and immunoadsorbent for SLE. And current types of hemoperfusion devices commonly used in China include activated carbon perfusion devices such as VITES 100 and VITES 160, and resin perfusion devices such as HA 230 and 280. So what's the difference between the two? Generally speaking, the absorption of activated carbon is non-specific and has absorption capacity for many organ metals. However, adsorption resin has high adsorption rate for various lipophilic and hydrophobic substances such as bilirubin, aromatic amino acids, and organophosphorus pesticides. From the expert consults on clinical application of pediatric hemoperfusion in 2018, and present the main disease used by hemoperfusion in children in China are poison, including drug poisoning, chemical poisoning, and bird toxin poisoning. Then the second about the immune disease, such as severe allergic purpur and SLE, and inflammatory disease such as sepsis and severe hepatitis. Other diseases such as uremia, thyroid crisis, tumor, chemotherapy, and so on. Hemoperfusion can remove a variety of poisons such as barbiturates and non-barbital hypnotic sedatives and the antipsychotic drugs and the antipyretic allergistic drugs and cardiovascular drugs and the herbicide, insecticide, paraquat, organophosphorus, and others such as the anti-cancer drugs. This is a female child who was stung by bees on her head and face. After the mission, we first checked whether there were residual broken strands in the skin of the head and face. We need to first shave the hair and took out the broken strands, washed her skin with normal saline, then smeared with glucocorticoid ointment, and then treated with hemoperfusion. So these two pictures are children bitten by poisonous spider and bitten by poisonous snake. They are all killed after 5 times of hemoperfusion treatment. So these pictures showed a child with several HSP. After 6 times of hemoperfusion treatment, the patient was adversely improved. So HSP is a kind of systemic vasculitis mediated by IgA immune complex. Several HSP is characterized by severe organ involvement or necrotic rust. So hemoperfusion and cytokine inflammatory mediators and immune complexes in the blood can be removed. So this is a child with several drug allergic dermatitis. After 6 times of hemoperfusion treatment, we can see it improved significantly. So this is a case of X-form native dermatitis type drug eruption. After 5 times of hemoperfusion treatment, it's adversely improved. In our department, we complete about 300 cases of hemoperfusion every year. Many children with HSP followed by poisoning patients caused by various reasons. The cost of each hemoperfusion is nearly 800 yuan. Finally, we emphasize the precautions of hemoperfusion. First, hemoperfusion is an invasive operation with certain risks, especially the establishment of vascular access in children, which requires the operator to master the operation process of hemoperfusion. Especially for the low-weight children, adequate pre-flush and reasonable angulation are the key to ensure the smooth process of hemoperfusion. Because hemoperfusion cannot correct the imbalance of water, electrolytes, and acid-based balance, and the clearance effect of urine, nitrogen, and creatinine is not good. Therefore, in combination of hemoperfusion and hemodialysis or continuous blood purification should be used for any poisoning children with water and sodium retention and renal insufficiency. So I think it's very important to care about the safety of the hemoperfusion. So that's all for today's series. Thank you, everybody.
Okay, thank you, Dr. Guo. And then we move for the discussion. Please stop to share the screen, Dr. Guo. Okay, thank you. So, very nice talks. There are a lot of topics topics and hot topics to discuss. I have some question for our speakers, and then they so could further share their experience. Starting with Dr. De La Cruz. The first question is if you could give us some practical tips about the priming methods, and in particular which is your strategies to avoid some complication typical of the low body weight in children, for example, the hemodilution or problem of piastreinopenia and so on. Do you use some particular strategy to prevent this problem in children?
So whenever we have a referral, what we usually get first is the weight. So we would know if this patient would need a blood prime, because in a hospital, it's you have to ask blood from the blood bank. So so we calculate all the extracorporeal circuit. So that would include the bloodline. So in our center, we don't have the pediatric bloodline. So we have a default adult bloodline. So that's around 128 mils. And if you, the HA330 is around a priming volume of 185 mils. And if we calculate the estimated blood volume of this patient. So if the estimated blood volume and the extracorporeal volume exceeds the 10% of the blood volume, then we need to do a diluted PAC-RBC prime. So usually with the setup that we do, if the patient is 45 kilos down, if you're doing the a circuit wherein you have a adult bloodline and a hemoperfusion cartridge, which is the HA330, and this patient also is suffering from fluid overload, you might want to do simultaneous PIRT, because you have to address the fluid overload. And some of these patients are also acidotic already. So usually we set around a 45 kilogram cut-off weight. If your weight is below that weight, then we need to do a blood prime. So that's our method in our unit. As for the other complications, it's usually just some during initiation. So there may be hypotension during initiation, but usually we have our intensivists on board, so they are there, so they will take care of these hypotensive episodes.
Okay, thank you. I understand that you use an intermittent hemodialysis, pediatric intermittent hemodialysis combined with hemoperfusion, correct?
Yes,
okay.
Yes, we do combine.
Okay. And during the session, did you experience some problem of hemodynamic instability in when the patients need vasopressor and inotropes? And usually, when do you observe a significant reduction of the vasopressor load? After how many sessions of hemoperfusion?
The decrease in the pressure dose, we usually see it just only after the second session. But it is mindful to note that when we do hemoperfusion, this is our own experience and observation, Like if you do a hemoperfusion for 2 to 2.5 hours, that is isolated hemoperfusion, then you go and proceed to the PIRT, you usually don't have that much good improvement in BP yet. It usually, you will need to wait at least 1 to 2 hours before the BP stabilizes. So usually when we count the hemoperfusions, it is 2 to 2.5 hours. Then then we proceed with the PIRT. Then usually that would around start 1 to 2 hours. We don't start ultrafiltration. Then if we have a stable BP already, then we start the ultrafiltration. And as we go along the PIRT, we go and increase the ultrafiltration dose until we are able to reach what we are targeting for that day. That's the reason why also that sometimes we go over time because we have not targeted the UF for that day.
Okay, thank you. And a question for Dr. Guo. Did you prefer a particular type of anticoagulation to perform your blood purification with hemoperfusion and RT?
The primary method, hemoperfusion. Yes, according to the guidelines, heparin can be used as anticoagulant. The first dose is 0.5 to 1 milliglotters per kilometer, and the additional dose is 10 to 20 units per hour. No molecular weight heparin can also be used for anticoagulation. Generally, we use 80 to 100 units per kilogram. Intravenous injection 20 to 30 minutes before treatment is recommended without additional dose. However, according to our experience, we can directly choose unfractionated heparin 1.0 without additional dose within 2 to 3 hours. Oh, okay, that's my answer.
Okay, and a question for both. Which range of blood flow per kilo do you use?
The adverse events. Yes. The hypertension is the most common complications in the process of hemoperfusion in children. And it occurs most often in the initial stage of hemoperfusion. When child have hypovolemia or stroke, they should be given hypovolemia and anti-shock therapy first, and then hemoperfusion therapy should be performed after blood pressure is stable. Patients with heart failure should be treated with anti-heart failure first. If the patients are young or have anemia, they should be pre-filled with normal saline or plasma or whole blood before hemoperfusion treatment to prevent hypertension.
Okay, Dr. De La Cruz, which is your blood flow range for the hemoperfusion on the basis of the weight of the children?
So we usually incorporate also our blood flow according to the weight. And because we are doing a simultaneous PIRT, we follow the blood flow rate for the PIRT. For example, if you have a less than 20 kilogram child, the blood flow rate would be around 30 to 75 mils per minute. And if it's 20 to 40 kilogram child, it would be around 75 to 125 mil per minute. Another way to compute it is around 3 to 5 milligram per kilo per minute. So if usually if you don't have, this is for, because we're also doing the PIRT, so we just followed our blood flow for PIRT. So if the circuit is heparin free, we do usually a 5 ml per kilo per minute blood flow.
Okay, thank you. I would like to share also a specific answer by Dr. De La Cruz in Q&A, and attendee ask about how long she used the cartridge. And Dr. De La Cruz, can you answer to all the attendees your strategy about 2.5 hours? I have understand.
Yes. So because we are preparing the whole circuit already, so we do a series wherein you have your hemoperfusion cartridge followed already by your dialyzer. So what we usually do is run the blood of this patient for 2 to 2.5 hours, just isolated hemoperfusion. We don't dialyze it, we don't ultrafiltrate yet, so we just do isolated hemoperfusion. So we can maintain that this patient is in a stable condition. So if after doing the isolated hemoperfusion, then after that time, then we start either isolated ultrafiltration, or sometimes already in combination with a clearance. But if these patients come in very fluid overloaded, what we do is try to ultrafiltrate first. But if these patients are also acidotic, we try to incorporate already the dialysis, the clearance of these patients, as to help the pressors to work, because if you know, if your patient is acidotic, your pressors won't work that much. So that's how we do it. And usually it depends on the stability of the patient, the tolerability. If we can ultrafiltrate at least a target volume for that day, then that's how we calculate how long we will do the PIRT. So it changes every now and then. If the patient can tolerate higher ultrafiltration, then that would be better.
Okay, but the hemoperfusion, how long last? 2 hours?
2 hours, but it's isolated hemoperfusion. Then we don't remove the cartridge. We just leave it there. Yes, we just leave it there.
Yeah, you leave the cartridge there. Okay,
yes.
Okay. And I know that you don't do the continuous renal replacement therapy, but it's interesting to talk about also the opportunity, if is possible, of course, to combine with the continuous renal replacement therapy. With this technology, hemoperfusion is available also with a continuous renal replacement therapy, correct?
Yes, if you have a CRT, it's better because you won't have the rise again in your fluid overload because you are in a continuous therapy. However, in our setup here in the Philippines, sometimes we have 4 to 5 patients having the need to do hemoperfusion. So if we also have the CRT, or we just have one machine, we still have 3 to 4 patients who need hemoperfusion, and together with ultrafiltration and dialysis.
Okay. Thank you, everyone. If there aren't any question for our speaker, we can close this webinar. Thank you for the wonderful organization. I think today was an important moment to share our experience, and I hope for next moment of meeting also in the future. Bye.
Bye-bye.